Schein for being here. I appreciate that. So I'm going to be very frank with you and talk about where I am in my career right now and why I'm at a different place than I was not too long ago, a few years ago. But primarily, I want to share with you a few things that I feel are holding our specialty back. And I say specialty as a collective. There are clearly progressive orthodontists that are not being held back. But sadly, some of the louder voices in orthodontics are prevailing with thought patterns, in my opinion, that are preventing us from not only providing better patient care, but competing in a market that has clearly realized that our patients are customers. They are less a patient, more a customer, because they have discretional income. No one's ever died from a malocclusion. And frankly, half of the things they have going on in their mouth, they don't know until you tell them. Once that realization hit me, it changed everything for my practice, and it flourished in a way that I never anticipated. So I want to talk to you just very briefly about some of the things that compelled me to join forces with Henry Schein. I've been associated with corporate orthodontics since I started. I had a couple of U.S. patents that intrigued some companies, and one company bought the rights to a patent, which started me on the path of discussing these things with people. And then I decided that I didn't want to, I enjoy teaching, but I didn't want to be a one-trick pony, talking just about the thing that I had patented. I just wanted to try and be an exceptional orthodontist. So I modeled myself after a couple of orthodontists, maybe three, that I thought were some of the most exceptional in the world. One of them is standing right over there. His name's Stuart Frost. He's my very best friend and one of the best clinicians on the planet, and he taught me a lot. We both learned from some extraordinary, We both learned from some extraordinary clinicians who, in my opinion, repeatedly provide results that I still am not able to provide on a consistent basis. It's frustrating, but it's the only way that you can be a better clinician. You can't do it by going to lectures. You can't do it by going to a weekend course. You can't do it by going to an ortho residency. The only way you can do it is finding somebody that you revere because of their clinical acumen, and then glom on to them and follow everything they do. Everything they do. Watch what they do when they're next to a patient. Watch what they do when they're holding an instrument, when they're bending a wire, when they're talking about the progression of an arch wire. And before you know it, you do it in a dedicated fashion, you're there. And so that's what I try to tell all the residents that I come in contact with and other doctors that are asking about how do we become better clinicians and have excellent finishes. So one of the primary things that in my opinion, finally revolutionized biology and married it with traditional orthodontics, which has had biology wrong for these many years as far as how tooth movement actually works, was self-ligation. And so I want to talk to you about some of the things that I am excited about with this system. Let's see if my clicker's working here. There we go. Some of you have seen me share this quote. I got a degree in philosophy, and Voltaire is one of my favorite philosophers, and I think this is my favorite quote from Voltaire. This is applicable in religion, family life, professional life, political, you name it. It is extraordinary how much we revere the very things that are holding us back from whatever, right? And there is no exception in orthodontic education and orthodontic practice. None. So I don't want to indict orthodontists that do this, but I do want to share with you some of the things that I think are revered, but that are chains and are preventing us from not only providing excellent patient care, but they're also preventing us from competing on a level that is legitimate in a workforce that has been transforming at lightning speed right before our eyes. And should we choose not to do that, we're going to wither on the vine. Should we choose to embrace, then we will prosper, and we will provide great patient care. Since the first day I practiced in clinical practice, wow. Hey everybody, check it out over here in booth, whatever we are. So, twin bracket therapy, obviously, that's how we got started. And the biggest problem with twin bracket therapy, in my opinion, is that the friction that is developed in an additive way using elastomeric or even steel ties prevents us from doing the things that we know we can do in order to provide brief but meaningful treatment for patients. What do I mean by that? Listen, if you can't do the things that self-ligation brings to the table, then you're going to end up extracting a lot. And listen, I extract, but not much. I would say maybe 1 or 2 patients a year, maybe, that truly need extractions. I couldn't do that if I was doing twin bracket therapy because I couldn't get the expansion, I couldn't develop the spacing, I couldn't control the torque on the incisors and things like that. So I think it's really important for us. And that's why, for crowding anyway, we revere the fact that if we see crowding, I was taught this in my residency, if we see crowding, the first thing we do is pull out teeth. I think that's a travesty. The reality is, almost every patient that I've encountered, at least in my private practice in 16 years, has not needed extractions for crowding, and the only real exception to that is somebody that is severely crowded with extraordinarily wide arches. Because if they've got extraordinarily wide arches and you can't develop the transverse, which is where you get most of your space to resolve crowding, then you're stuck, right? And so in those patients, you are obligated to find a way to create space that doesn't compromise the periodontium and the teeth and the roots and all of that. We won't get into this today. There's only one time in 16 years, one case set of patients that I use rapid palatal expanders, and that's for airway, for kids who have a severe airway constriction, and that's for another day. All other kids, whether they're in crossbite, if they are crowded, they, in my experience, do not need rapid palatal expanders. And we've got lots of evidence to demonstrate that rapid palatal expanders are not benign. In fact, we've got a lot of evidence to demonstrate it clinically. If you just look at a 30-year-old woman or man that comes into a dental office and they have got recession bilaterally from the canine's back or from the first bicuspid's back in the absence of inflammation, then by definition that is not a disease process. That is not perio. It's not perio disease. Can't be, because it's in the absence of inflammation. So something caused that recession. If you ask those patients, did you ever have a device in your mouth that your parents cranked, well over 80% of them would say yes. So it's for another time. And the reason that I do it on airway kids is I don't have the luxury of a year of transverse development and biologic adaptation to create the transverse and get the spacing resolved, because these kids are scoring cognitively lower. They're getting pigeonholed into ADHD camps where, because they can't sleep at night, they've decided a good idea for that is to give them amphetamine analogs, and which is obviously the opposite of what would be the best thing for those kids. So this thing about treatment times of 2 years or more, we have got to get better. Some of us have. If we don't get better than that, then we are truly in jeopardy of losing the vast majority of our patients, especially adults, because adults are not willing to sign up for 2 years of treatment. They're just not. And guess what? Neither are general practitioners. They don't want to send their patient and know that they're going to be in treatment now for 2 years or more to resolve an orthodontic problem. We have got to get better at that. We have got to get to treatment times that are much shorter than that. In fact, my goal is, in my practice, which is the way it is now, is if my patient's at 18 months, I'm really searching to figure out either what I did wrong, why this isn't working. 18 months is a long time, and it shouldn't be that long. You can't do that if you extract a lot. You just can't, because extraction takes a lot of time to close spaces. But let me tell you something. It's why 6 Month Smiles was purchased by the Huron Investment Group for $300 million 5 years after it was started by a general dentist. Because they figured out people want to have their smile better, and they don't want to do it for the cost of being in treatment for a long time. They figured it out. And I'll tell you something. When you have a private equity firm that comes in and buys something for $300 million, that's other people's money. So they do their due diligence. They understand without a jaundiced eye from an orthodontist perspective, and truly ask these patients, why are you avoiding orthodontic treatment? It's time. It's not money. It's time. And then transverse correction before sagittal. And that's the way I was taught, transverse before sagittal, and doing it the other way around has changed everything. But I'm not going to talk about that so much today. One of the things that I want to briefly touch on is I gave a presentation to the Utah Association of the Utah Academy of Dentistry, and they wanted to know why we extract so much. So I did my homework, and the long and the short of it is, you would be astonished that the reasons that we extract are dogmatic and personality driven, not scientifically based, and certainly not based on the outcomes that patients are expecting or that orthodontists promise. I would encourage you to do a deep dive into that. I would encourage you to do a deep dive into the history of how it radically changed from almost zero extractions to an incredibly high extraction rate, back down and then back up, and ask yourself, what are the motives and what are the things that are causing that? Because if you can't have an honest discussion with yourself about that, then I don't know if you really know the best way to treat your patients. That was the first patient I ever treated. I wouldn't do this again. This is a different way than I would treat. The torques are off and the canines are rotated. But what I do want to show you, very first patient, I came into private practice. I put self-ligating brackets on. This patient, her religion was such that they were fearful of extractions because they thought if we have to have a blood transfusion, which obviously doesn't happen when you have blood, tooth extraction, but of course they're parents and they're thinking of the worst scenario. They can't do it because their religion doesn't allow for that. And so it was either no extractions or no braces. And this girl didn't even know how to smile. I'm not going to even show you all the details of the case because we don't have time. But what I do want to show you is the gingival health. The fact that we did get beautiful expansion, and we did get expansion not necessarily at the expense of pushing roots through the bone. All of that, I think, would be extraordinarily difficult. Look at the change in the arch development. That's tremendous, beautiful expansion. It takes time, right? This is my first time I ever did this in 2004, and it took me a while. This case took me 33 months, primarily because I didn't know what the hell I was doing. It was my very first case. I was in a practice I had bought from a guy, and he's like, you're on your own. You need to figure out how to treat patients in the real world, right? But it did demonstrate to me that there are better ways to treat patients than just jumping to extractions, even in severe cap crowding like that. And I'm not saying I wouldn't extract on a patient like this. She probably would be an extraction case. However, I want to just show you, and some of you have seen me show this before, but it really demonstrates the passive self-ligation, and the whole reason that I'm here, and the whole reason that I work with Henry Schein, and the whole reason of my path of being with other companies is because of the fact that we can resolve very significant crowding. By the way, if you look at that lower arch, and I'm going to be really fast, if you look at that lower arch, it tells you right now, that's not a good idea to extract primary canines in the face of crowding of the lower incisors. There's no benefit to it. Other than it resolves some of the crowding temporarily, if there's no benefit to it. In fact, now you got to make up the space. That's what happened to her. What happened to her was that she had primary canines extracted on the lower, and guess what? Her incisors lined up beautifully at the expense of all the space that the permanent canine needed to have to erupt into the mouth because of the pressure of the lip. Happens almost every time. So if I've got primary canines and crowded incisors, I just either start phase 1 if I need to, or I tell the parents, listen, these crowded incisors are going to go away. We're going to figure that out, but we don't want to do it right now. Anyway, the long and the short of her case was, and I didn't want to change her profile because she already had thin lips, is that I did just regular, this was a long time ago, so I treat a little differently now, but look at the expansion, look at the difference in the arch. You can do all of this, and you don't have to do extractions. And you can do this not at the expense of periodontal compromise, but you can do it by a combination of distalization, of expansion, all of that. Those are the virtues, in my opinion, of using self-ligation. And so that's one of the primary reasons that I'm even here today. And so what I'm going to do is I'm going to move forward, and I'm just going to show you this case really quick because this kid was sent to my office by a general dentist after I had talked to him at his office about, I gave a presentation to his staff. And he'd already sent this kid to another orthodontist in our community that he'd been sending to for a long time. And he called me and he said, based upon what you've told me, I'm very uncomfortable now with their treatment plan. Could you just look at him? And I surely did. You can tell, I mean, his palate looks almost exactly the same as that girl. So you know, because I showed you, you know that this is totally treatable without extraction, doesn't need extractions. But here's the saddest part of all. When I looked at his panoramic x-ray, they had already extracted his bicuspids that hadn't even erupted yet. Not only that, then they were told that he needed to be in phase 1. And I don't know what he needed phase 1 for, because they just took out 4 perfectly good bicuspid teeth that they didn't need to take out. It confuses me, and I wasn't sure. This means why the 4? Why the 4 bicuspids extracted? Why? Why did you extract those 4 bicuspids? Don't be dirty in your minds, you nasty people. Don't be dirty. Anyway, all right, so the long and the short of it is, and I'm short on time. I just want to show you. This was an orthodontist that extracted all 4 bicuspids in the maxillary arch. The first molars are touching the canines. That is her bite. The dad begged the orthodontist, took him to lunch even, and said, please, I don't know, I'm not telling you your business, but this isn't right. She doesn't feel right. I don't know what's wrong. And he said, nope, she's done with treatment. That's all that we can do as orthodontists. And so the long and the short of it was that it was a tragedy. So I just created space, put 2 implants in. I couldn't generate space for 4 in a reasonable amount of time. But the difference in somebody's case that doesn't have missing tooth units is remarkable. And if you compare that to where she was, the girl on the right looks way younger than the girl on the left, but she's older than the girl on the left. It's sad, and I see this over and over and over again. It's just absolutely remarkable. And airway changes, we're not going to get into the airway changes, but it's significant, it's impactful, and and it's just another reason. Aligners have taught us that light forces are beautiful, that low friction and light forces, this is 8 months of treatment in aligners. 8 months of treatment in aligners. Correcting deep bite, getting more expansion, this is 15 months of treatment in aligners. 15 months. Light forces, continuous light forces, are far better, in my opinion, for everybody, patients included. So, what we decided to do when we were looking at the brackets that were on the market, the existing brackets, is we decided to find out the pain points as an orthodontist with what we had currently for passive self-ligation. And so what we wanted to do is make sure that we had the best control possible. The biggest problem and the biggest complaint for passive self-ligating doctors is they say, I can't finish. I have trouble finishing. It's a struggle. I'm doing a lot of wire bending. And part of the reason is that we've not only got slop between the wire and the bracket, but we also do not have a lot of interface between the bracket door and the wire. So we decided to create one that goes the entire width, and it makes a big difference. It makes a huge difference when you're talking about control. And so if we were able to do that, then we would have a lot different result. So we tightened tolerances, we expanded the door, we did a lot of things that really, I'll tell you why it was fruitful for me. When we did this design change, and it really, and I'm going through this kind of fast because I have to be at another presentation at 11:40, sorry about that, but I want you to look at that. The entire bracket is controlling the rotation of that tooth from the first day that you put in light wires, instead of just a part of the door controlling the bracket. That's meaningful. That's really meaningful, because you get alignment on a much quicker than you would if you didn't have that advantage, that mechanical advantage. This was, and still is sometimes, but I mean, this is not uncommon, and many of you know that, especially if you're doing passive self-ligation. These are finishing wires, right? And wire bending is not a bad thing. Wire bending is great. I love it. It's my zen. It's what I like to do, but I shouldn't be doing it a lot to the point where it slows me down in my clinical practice. What is the proof that capitalizing on all of these mechanical advantages with bracket systems and wires actually has a meaningful change for me as a clinician and a business person? The proof is that I don't do pano repo visits anymore, and I haven't for almost 4 years now. I stopped doing them because they were not fruitful. We would have an hour set apart for every patient to come in when they were midway through treatment, to sit them down and look at the brackets that we wanted to reposition because of the way that the teeth were misaligned. And we weren't doing that very much. In fact, we were only doing 1 or 2 of these bracket repositions on average on a patient, so we got rid of that entire category of treatment, which obviously opened up the time in our clinic. And the other big thing that we did that I'm not going to talk about right now, but I'm just going to say it, I'm going to put it out in the ether for you so that you can be weird and freak out, but I don't do retainer visits either. There's no reason for them. It's a bad practice. No other specialty does it, and it's a waste of time, and there is no good retainer visit. There is no good retainer visit. Either everything is great and the parents and the patient are wondering, why do we get out of school and waste our time for you to look at this, or it's a bad appointment. So we won't get into that right now. But the reality is, the things that we have put into the bracket to help not only us as doctors, but our assistants in bonding and debonding are meaningful. They're meaningful changes. We've intentionally done things to allow us to put these on the teeth in a way where they actually feel like they're falling into place. You know, previous brackets that I worked with, the only analogy that I can think of as a clinician putting them on a tooth is like super gluing a dinner plate to a tree trunk. There is no place where it feels right. It just, maybe it looks like it's supposed to be there, but it doesn't feel like it's supposed to be there. I'm just going to hold it there until I cure that adhesive. Well, that's different when you have bases and widths of the brackets that are different based upon the widths of the teeth. It makes a lot of sense. If you've got really wide brackets and they're all the same size, and you put them on teeth that are smaller than the ones on the top, now you've got very small inner bracket distance because you don't have a differentiation between the widths of those brackets. And so, at least for me to be an outstanding clinician, in my opinion, I had to finish in a smaller wire on the lower than I did on the upper because I needed to capitalize on not filling up that bracket because they were so close to each other. That's different for me now too. I now finish all my patients in 1925 TMAs, upper and lower. I didn't used to do that. It was always a 1725 on the lower. What does that do for me? It allows me to have further bracket expression. It makes me a better clinician. And so we put a lot of thought into that. I'm not going to go into the details of the spring, but it's impressive. And the thing that I like about it is that, and we won't go through all of these because it's kind of self-evident when you start looking at it, and we've got all of this information if you want it. So one of the things that we're searching to do is to get to a sequence of wires, and everybody's doing this. I mean, everybody's been trying to do this for years. To get to the golden chalice is one wire. And let me tell you something. We're going to get to one wire someday. Not we, us here, but somebody somewhere is going to get to one wire because we have programmable metals now. Programmable metals that change their structure based upon external input. Electrical input, energy source, changes the configuration of the wire. There will come a day where we put one wire in a patient that fills the bracket slot but is dead soft, and then when they come in, whatever we do with whatever we have to do to activate it, it changes the structure of that wire and allows us to finish in the same wire. That will happen, I promise you. And it's not going to happen in 20 years from now. It's happening. People are working on that technology right now. So what do? I typically do an 015 round wire, a round Nai-Tai wire, and then I move to a 2020 square wire. The 2020 square wire is soft enough for me to still get it in with moderate crowding, but allow me to start working on torque and keep that wire in the patient for a while and let it express. One of the things that I found was a problem for me going into a 1425 Nai-Tai and then going into in an 1825 Nai-Tai. The 1425 was nice because the biologic system was not overpowered, was still in charge, and the wire wasn't overpowering it. Then I would put an 1825 in, and it started in many patients to overpower the biologic system, and so it wouldn't allow those arches to coordinate as easy. This does. And then I move from that into a 1925 CNA is the wire that we have and use the same exact thing. And then we allow for detailing. So we had 3 practices that were using a competitor self-ligating bracket and 3 that were using this one over time, and this is what they found out. They found out that this is times fewer on the y-axis. You can see that everything went down, especially total months on average went down. This wasn't in my practice. It was in 3 other practices that they did this. And all of this is independently verifiable. You can get all the data. The reality is you do this in combination with all of your patients and changing and modifying a few things in your appointment and scheduling. Does it make you profitable? It surely does because you can see more patients. I only work 3 days a week. I used to work 5 days a week, and I used to see 120 patients a day, and it was ridiculous, and I didn't know my patients very well. I didn't know the parents. I didn't know. Now I spend time, and I know every one of them. And my sweet spot is 55 patients a day, 3 days a week, and that's it. And I love it. It doesn't get any better than that. And the reason is, and it's not a chaotic clinic. The reason is I'm putting all of these biologic changes that we have built into the bracket system and the wires to allow us to capitalize on mechanics and biology. You couple that with using sagittal first, taking off the AP correction from the end of treatment that usually is the thing that held all patients captive, getting them into a bigger wire, so now you start rubber bands. They hate you already. I mean, you've been in treatment now for almost a year, now you start rubber bands. They don't know why they're starting rubber bands, and yet you feel compelled to yell at them because they're not wearing their rubber bands. Well, it's no wonder that they get frustrated with us. If we do that at the very beginning of treatment, even when they're not in braces yet, even when they're not in aligners yet, we just correct the AP in the first 3 to 6 months, holy cow. They walk into our offices, they're ready. They're ready to give somebody money to change their life and not change their life in a very good way temporarily. They know that. That is what they've geared themselves up for. Capitalize on that. Do it all in the front so that they don't resent you in the end. And that has changed everything. The conversations in our practice are very different now. There's not a lot of, hey, can you go please get her mom and let's go talk about this? That doesn't happen almost ever anymore. And the other thing about it is that they see, because they don't have brackets all over their teeth, there's only one thing you're doing when you're doing that sagittal first. They know what they're doing. They know why they're doing it, and they see the changes happening. Their head is in the game. I couldn't want a better patient if I had a patient whose head is in the game and knows why we're doing what we're doing and they're motivated to do it. So anyway, in those practices, they found out that their practices were far more profitable, which ultimately ends up in greater happiness. I'm trying to get more zen every single day of my life. I'm trying to do things that minimize negativity and enhance happiness. And this is one of the things that's really helped me out. And I'm not kidding you. Come visit my office someday, and I think you'll find that the environment in my office is happy. It's very, very happy. Thank you guys very much.
Great. Thank you, Dr. Graham. Great.